record, and then we'll go ahead and start. We're going to talk about, we're going to talk about both exercise-associated collapse, and we're going to talk about exercise-associated hyponatremia, but we're going to talk about exercise-associated collapse first. So this is not a CAQ question up here. This is from some old article that somebody decided to put their name on the stages of collapse for exercise-associated collapse. You have here in panel A, you have the early Fosters. In B, you have a half Fosters. And then in C and D, you've collapsed down to full Fosters. So just you can put your name on and publish anything if you have the right journal. All right. So goals and objectives, understand what it is and how to diagnose it, when to diagnose it. Feel comfortable treating it in a medical tent. And then obviously somebody comes in and collapses. There's a few things that could cause that. And so making sure that we can distinguish EAC from something else, okay? And this will absolutely be something that will walk in to the triathlon tent on multiple occasions. So just here's a case example, 27-year-old male comes into the medical tent after a marathon. He was found collapsed just after the finish line, and he is kind of walked/dragged into the medical tent with his buddies. He is able to communicate to you that he's dizzy, he's lightheaded, and he feels really weak. This is his first marathon. He's been training for the last 5 months. He is on medications. He says he takes Prozac for anxiety. And he does relate that he did have an episode of runner's trots. Do you guys know what that is? You have to trot to a porta potty very quickly or to the woods. So runner's trots is diarrhea. But only once. And he did have a cup of water at each of the 5 water stations throughout the marathon. He does also complain of some abdominal cramping. Kind of looks like this. He's a little sweaty. He just looks really exhausted and mildly pale. Blood pressure is in the normal range. He's a little bit tachycardic. He did just run 26 miles. But his cardiac exam is normal. Temps 100.2. And his lungs are clear, and he's really able to communicate with you. Once he's lying down, he's really pretty communicative and able to answer in a cognitively appropriate sort of way. So any guesses? 40% of EAC patients demonstrate moderate dehydration. True or false? All right, we'll get there. So what is EAC? So really, this is the fact that you collapse after exercise. The key here is after, okay? Collapsing during exercise, much scarier. That potentially is something cardiac, okay? So this is absolutely after exercise. The other place that you guys will see this is like, is it the KVACs, right? They're running the 5K. So I think literally everybody who crosses the finish line at KVAC races will collapse, and then you're going to have a pile of people at the end, and just keeping people moving is really important. It is associated with feeling dizzy, lightheaded, sometimes syncope. And really, this is a blood pooling and blood distribution problem. This is not a dehydration issue. Can you be dehydrated and have this? Absolutely. Is it a requirement? Absolutely not. Okay. So a lot of the people who have this are not actually dehydrated. They are just experiencing an acute hypotension. For people who have more severe cases, there might be something else going on too. You have to think about something called hyponatremia, which we'll talk about at the next talk. And then if they've collapsed again during the race, this is often something that is life-threatening, and they need to be transported immediately. So just case in point, this gentleman, Matt Campbell, 26 years old, he collapsed at mile 22.5, the London Marathon, cardiac arrest. And so if you have somebody who's experiencing issues during the race, you really need to be worried about it. As Chris and Rob alluded to, I have a little thing for algorithms. So welcome to my first algorithm of the year. All right, so this is, as I said, a blood pressure issue. What are the 2 factors that play into blood pressure? What are the two components that affect blood pressure? This is Med School 101. Yeah, so total peripheral resistance. Good. What else? Very good. Okay, so when you're running a race, you have various things which are going to affect both of these. Okay, so first of all, when you're running, you've got these large muscle groups working, they're going to be demanding more blood. And so what's that going to do to total peripheral resistance? Yeah, so you want more blood to flow to those areas. So your total peripheral resistance is going to go down. Most of these races are in the summer, high heat and humidity, right? What happens when it's hot out? What are you going to do? You're going to vasodilate. You're going to get rid of some of that heat. So you're going to vasodilate. You're going to have more blood flow to the skin. What's that going to do to your total peripheral resistance? It's going to go down. Exactly. And then what else do you do in the high heat and humidity? Sweat. Exactly. So you're going to have fluid losses, right? Decreased fluid volume, which is going to lead to decreased cardiac output, correct? So how do you maintain flow to your brain during all of this? You're running, you've got these two giant legs. Oops, I'm sorry. And then in this case, we've got a case of somebody's had some diarrhea. So he also has some fluid loss there. So, so that can also weigh into it. And when you're running, you've got these two massive pumps that are squeezing blood out of your legs back to your heart. And so you're going to make up for that decrease in blood pressure by pushing that blood, increasing your cardiac return, which is going to increase your cardiac output. What happens when you finish the race? You stop running, all that blood pools and down you go, right? So you take away the pumps, you take away that increased cardiac return, your blood pressure suddenly plummets, and then you collapse shortly after the finish line. Okay. So, and then your dizziness, syncope. There is a receptor that nature has built in. Nature, unfortunately, didn't count on us running 10Ks and half marathons and half Ironmans and all that sort of stuff. But the baroreflex is nature's way to kind of prevent this from happening. It's a pressure mechanoreceptor in the aortic arch, and it responds to changes in pressure. However, it does not seem to really respond to decreased pressure in the legs. And so when those pumps start working, it doesn't seem to trigger the baroresponse as much. This is actually more of an issue for people who have really acclimatized to running quite a bit and who are really experienced runners. Their baroreflex is actually blunted even more. So you can see this certainly in very experienced runners, in addition to people who are not typically experienced runners. It can also be affected by heat, by low blood sugar. So a lot of medications can also blunt this effect too. So as you know, from our case, he's on Prozac, he's on an SSRI, and so that can blunt the baroreflex. There are H1 and H2 blockers can activate the baroreflex actually. And there are people who they know that they're prone to EAC, they're on an H2 blocker to kind of prevent that, and that can actually really help them. So there are people who do take those medications to help with this. So for endurance athletes, you've got just increased lower extremity compliance, increased diastolic chamber compliance. And so actually it can be more of an issue to the baroreflex. They don't respond as much. And so they can be even more prone to collapse. They're more dependent on that venous return from their hearts. All right. So true or false, vital signs in exercise-associated patients are typically normal. True. Yeah, very commonly can be very normal. There are a few, your heart rate can sometimes be a little bit elevated. Sometimes your temp is a little tiny bit elevated, but for the most part, they can really be normal. Just like this cameraman kills me every single time. So remember, this is not dehydration. Typically, people are not dehydrated with this, except for in severe cases. It is not heat stroke, but heat stroke needs to be on your differential, right? So many patients are normothermic. When they've compared people with EAC, their temps to people who don't have EAC, it's really not a big difference at the end of the race. But you may see more exercise-associated collapse if it's warm out, okay? It is, again, not cardiac. And again, that's where we're thinking if somebody has an event during the race, you think cardiac. I will say I have had a case where somebody walked into the medical tent and they were having an MI though. So just because it walks into the med tent doesn't mean it's not cardiac, but just bear that in mind. Okay, so remember, if you have severe cases of exercise-associated collapse, there can certainly be something else going on. And so you do want to kind of, again, think about getting labs on anyone who is confused or doesn't seem to be mentating. Make sure you're getting a rectal temperature. They're very often going to be tachycardic. They just ran a race. Okay, so they're going to be tachycardic from that. They're going to be tachycardic as a response to that decrease in blood pressure. Their blood pressure might be normal. It might be a little bit high. It might be a little bit low. Okay, so about half of patients typically have a slightly low diastolic blood pressure, but it can be very normal. All right, which of the following is correct? EAC is responsible for about 20% of post-race med visits. Hyponatremia, hyperthermia, or hypothermia may be seen in severe cases. EAC is more common in cooler weather races, or symptoms that do not respond to Trendelenburg indicate likely EAC. Yes, correct. B is the answer. So this is, again, one of the biggest thing that you're going to see in the med tent is exercise associated collapse. Okay. In the Twin Cities Marathon, about 1% of all race starters experience this. The Germans apparently were a little tougher, about 1.5 per patients out of all 1,000 per 1,000 runners. Ultra distance, you're going to see it a lot more. So the longer your race is, you're much more likely to experience it. Ironman, 27% of race starters. Okay, so again, this is something that you're going to see at the Ironmans and the half Ironmans for sure. Average age is in the 30s. It's going to be more common in those who are inexperienced runners in longer races. Again, I feel like Rob here. So older female runners in half marathons. Have I had EAC after running a half marathon? Yes, I have. So typically, again, the people are just going to be exhausted, complain of fatigue. They may say they feel hot or cold, may feel nauseous, lightheaded, stomach cramps, headache, may kind of have that generalized cramp. So again, very similar to how Rob's heat exhaustion patient is going to look. It's going to be very similar to EAC. They may complain of palpitations. For mild cases, again, you're going to have somebody who's collapsed. They may be able to get up on their own. They may need some assistance. They may kind of have, they're going to want to kind of lean forward when they walk. They're going to really kind of try to be getting really subconsciously that blood flow back to their brain. They may have some generalized muscle spasms. If they do have tachycardia, if you get them into a Trendelenburg position, that should really improve. In more severe cases, again, you're going to be thinking about if somebody has any confusion, you're going to be getting a rectal temperature on them. If they've got vomiting or diarrhea, again, you want to be thinking about other things that could be going on. They may be hyperventilating. They may be hyperthermic as well. So thinking about making sure that they don't have heat stroke. We've talked a lot about, but any ideas for differential diagnosis on this? Some of the things we've already discussed today. Heat stroke. Heat syncope. Yeah. MI. Yeah. Cardiac. Absolutely. Yeah. Yeah. So, and hyponatremia can also be something that presents like this too. Hypoglycemia. Okay. Don't forget, there are still things out there that people are allergic to. This could be an anaphylactic reaction, muscle cramps, dehydration. There is something called exercise-associated postural hypotension, which is if you're exercising. So think about somebody who's doing like rowing and then they suddenly stand up and have an orthostatic event. That's different than exercise-associated collapse. Hyponatremia, we're going to talk about that. Cardiac etiologies we're not covering today. We will be covering that later in the year. And then exertional heat stroke, Rob already discussed. Monitoring their mental status, continuing to have a conversation. How'd the race go? When did you start feeling like this? What medications are you on? You know, really kind of checking in with their mental status as you go. Ideally, rectal temperature, but if somebody is mentating with you well, and as Chris said, if they're like, hey, you know, I really would rather not have that rectal thermometer placed up my butt at this point, then they probably don't need it. But getting a temperature is nice. Checking their heart rate, following if they do have tachycardia, watching it hopefully go down, checking their blood pressure, kind of getting a clinical estimate of their hydration status. And when we talk about hyponatremia, we'll talk about why that's really important. They may have kind of a diamond pallor around their mouth and nose. And so that's pretty common to see in this. If they're grayed out, then you have to worry about, again, is there something cardiac going on? Thinking about getting a blood glucose is something that you can consider as well. And I think you guys have glucose monitors. Do you guys have glucose monitors in your? No. Okay, never mind. Never mind. And then thinking about, again, serum sodium, depending on, are they mentating well? Are they acting any confused? Do they look like they're kind of puffy? What else is going on? A lot of these people do have a little bit of elevated sodium levels. Hyponatremia is less common in shorter races, but when you get into the longer races, such as Ironmans and half Ironmans, you can see hyponatremia. Elevated lactate, again, this is based on studies where people have agreed to have this done. That you're going to see this in people who are regular finishers as well, elevated lactate levels, typically not associated with hypo or hyperglycemia. And this is just a chart kind of comparing the findings that you might get. Basically, to take away from it, if they have a more severe case, you're going to have more abnormalities on some of these tests, right? This is the treatment right here, okay? Is getting somebody into Trendelenburg position, redistributing that blood flow back to their brain. It is amazing how quickly they recover when you do this, okay? So I have even, you know, if somebody's at the finish line and I'm at the finish line and they do this, I'll like pick up their legs and start squeezing their calves. And it's like almost instantaneous that they're like, wow, you're amazing. How'd you do? It's like you have a magic wand and you fix them. And then you have to encourage them not to jump up because they feel suddenly a lot better and they want to jump up, and then they're going to just collapse on you again. So really just redistributing that fluid, getting their legs 6 inches above the heart. At Lake Placid Ironman, they have these old school, really super old school lawn chairs that like you had to like click one. They're like divided into thirds, and they're easy to clean because they're these weird plastic tube things that cover them. And so you could actually put the leg part higher and get them into Trendelenburg. Regular cots, this is a little bit harder to do. So those like 99-cent lawn chairs that probably are no longer made are really effective for this in the med tent. You can ask the patient to try to contract their own muscles, but it might be really hard for them to do. They might just be completely pooped. If they're cold, warm them up. If they're warm, cool them down. Fluids, oral fluids. If they are talking to you and not actively puking, oral fluids, okay? And then rechecking again every 15 minutes. If they have any altered mental status at all, and they don't appear to be dehydrated, or you lay them down and they're not responding quickly, check a serum sodium just to make sure that their sodium is not contributing to this issue as well. All right, so again, anyone who's worked an Ironman, I'm sure Jim could tell stories too of, if they can come in and they say, I'd really like my IV now. The answer is no. If you can take PO, you take PO. Okay. They can drink whatever they prefer. A lot of people want something with a little bit more salt and flavor to them. Gatorade is hyponatremic. It is not sodium, like pure isotonic solution. That's gross. It tastes disgusting. So, it's still like they're getting quite a bit of water just drinking Gatorade. If, they want, especially if it's a cooler day, having a little bit of soup bouillon, and I'll talk about this at the next talk, that can really help with fluid retention too, getting them a little bit of bouillon. Only if they're able to get no oral fluids in. If they have a lot of vomiting, diarrhea, if they're acting confused and you know their sodium is in the normal range, it's not low, you can think about IV fluids. So again, if they're not responding and their vitals are not going well, you're also kind of getting ready to arrange for transport to them too. But you want to, again, kind of think about getting an IV access and maybe even starting an IV as long as, again, you've checked that serum sodium. So bouillon cubes, I don't know if you've ever seen bouillon cubes. So you put the bouillon cube in like a quarter cup of hot water, and I'll give you a recipe of how many to use. Like you put 3 or 4 in a quarter cup of water, which is like liquid salt. Bouillon, even one bouillon cube is really, really salty if you've ever had it. So in the next talk, we'll talk about like hyponatremia. You could do 1 bouillon cube for somebody like this, and it's going to probably taste fairly good as long as it's not super hot out and they don't want to, you know, tolerate the because it has to dissolve in hot water. But so if somebody who's a simple exercise associated collapse, a little bit of bouillon can taste really good. If you're worried about hyponatremia, then a concentrated bouillon with like 3 or 4 of those in a little bit of water, which is like drinking liquid salt. Okay, so again, if you're giving somebody IV fluids, you want to be knowing what their sodium levels are. And then a rectal temp, again, is ideal if somebody is talking to you, walking, talking, and like getting a rectal temp on them is overkill. You don't need to do that. And then, you know, again, we talked about all this already, but thinking about putting some ice around if they are a little bit on the warm side. If they're cold for your fall races, warming them up is going to feel really good. And then the big question is like, what do you do with them after? Okay, so general rule of thumb is if they're clinically stable, if they're like sitting up on their own, they're saying, yeah, I'm feeling a lot better, and they're able to take PO, great. Go home, just take it easy today, make sure you're hydrating. So going from laying down to sitting up and sort of seeing how they feel, if they're feeling pretty good and maintaining that, they can head home. If they're, again, not doing well, if you sit them up and they suddenly plummet again, you know, that case that Chris talked about, that person who you just can't get out of the med tent, there might be something else going on. And so further assessment might be worth it. There is a British Journal of Sports Medicine algorithm that talks about this and sort of reassessing. But in my mind, this is a relatively simple thing to treat that they should, it's a sort of straightforward, lay them down, Trendelenburg, get fluid back to their brain, and they should recover pretty quickly in the vast majority of cases. Okay. Prevention, this is often going to happen for people if it's going to happen. And this is sort of what the end of KVAC, this is not from KVACs, but this is like the end of KVACs. Just disaster. There are some people who like to wear compression socks. There's no like great data on that. If you really like to run in compression socks, sure, you know. If you know you have some of those cooling stations, that's great. You know, if some of these more hot humid places where they're blowing a cool mist, maybe. We already talked about H1 or H2 blockers. This is a link to the algorithms that Chris talked about from the Marine Corps Marathon that you guys can certainly access and look at as well. Those are the references. This is a Hawaiian red octopus. And those they have these little suckers that really, really, really glom onto. So my daughter's ready to buy her ticket back to Hawaii right there. So that is exercise associated collapse. Let's see, stop share and stop recording.